Computer. Okay. Hi everyone. So I'm going to pass over to Charlotte, who's going to be giving an Orthopaedics for Finals talk. If you have any questions, obviously use the chat box or just unmute yourself. Otherwise, I hope you have a good session.
Thank you, Rachel. Hi everyone. So today I'm going to be talking about Orthopaedics for Finals. The topics I'm going to be covering is osteoporosis, osteoarthritis, rheumatoid arthritis, gout, pseudogout, reactive arthritis, psoriatic arthritis, and septic arthritis. I think my slide should be available to you at the end. So if you're unsure about anything, just pop a message in the chat and I can see if I can try and answer as we go along. So I'll start with osteoporosis. So osteoporosis is a reduction in bone density, whereas osteopenia is a less severe reduction in bone density, but both are just a reduction in bone density. This reduced bone density makes the bone less strong and more prone to fractures. So your risk factors are older age, female, reduced mobility, low BMI, so below 18.5, having also rheumatoid arthritis, alcohol and smoking, which is your risk factors for basically everything, and also if you're on long-term corticosteroids. So NICE suggests that the risk increases significantly with the equivalent of more than 7.5 milligrams of prednisolone per day for more than 3 months. Other medications are also risk factors, and these are SSRIs, PPIs, anti-epileptics, and anti-estrogens. So if you think someone may be at risk of osteoporosis, you start the investigation by completing a FRAX tool. So a FRAX tool predicts the risk of a fragility fracture over the next 10 years. So it's normally the first step in assessing someone's risk of osteoporosis. So in this tool, you need to input the patient's age, their BMI, comorbidities, whether they smoke, how much alcohol they drink, and family history. You can also enter a bone mineral density results, but if you don't have one, you can still use the tool without that result. And so, yeah, that will give a result as a percentage 10-year probability of suffering or having a major osteoporotic fracture or a hip fracture. So that's like the first sort of thing you do if you think that someone may have osteoporosis. And then you can then go on to do a bone mineral density scan, and that's used doing like a DEXA scan. So it measures your bone mineral density. You can take readings from anywhere in the skeleton, but it's most often taken at the hip. And DEXA scans are like brief X-ray scans, and they measure how much radiation is absorbed by bones, and that will indicate how dense the bone is. So it will then give a T-score or a Z-score, and that represents the number of standard deviations that the patient's bone density falls below the mean for their age. So as you can see here, the T-score, that represents the number of standard deviations below the mean for a healthy young adult of their bone mineral density should be, basically. So if it's more than -1, that's fine, that's normal. -1 to -2.5, that's osteopenia, which is a less severe form of osteoporosis. Less than 2.5 is osteoporosis, and less than 2.5 plus a fracture, that's severe osteoporosis. So like I said, so step 1, you'd firstly do a FRAX tool for all women aged above 65 or men above the age of 75. You'd also do a Fractal for like younger patients with risk factors. So they've previously had fragility fractures, they've got low BMI, so people with anorexia nervosa, it's frequent to do a Fractal on those people. If they're taking long-term steroids, endocrine disorders, and also rheumatoid arthritis. You'd then go on step 2. So you'd then look at the FRAX outcome, and if you didn't have a bone mineral density result and the FRAX outcome was low risk, you just reassure them. If they were intermediate risk, you would then go on to perform a bone mineral density scan for them and recalculate the risk with their results. If they were high risk, you just go straight to treatment. You wouldn't need to have to do a bone mineral density test as well. If you had a Fractal with a bone mineral density result, you can either treat or you can just give lifestyle advice and reassure. So the management, firstly, you'd give lifestyle advice of lifestyle changing, so obviously reduce some weight, stop smoking, all of your lifestyle spiel. You'd also prescribe vitamin D and calcium. The NICE recommend that the calcium is supplemented with vitamin D. So an example of this is Calcichew. That contains 1,000 milligrams of calcium and 800 units of vitamin D. Patients that have got enough calcium intake in their diet, but they don't have much sun exposure, which is basically everyone in the UK, should be given vitamin D supplements as well. You can also, bisphosphonates is also first-line treatment for osteoporosis. So this medication works by interfering with osteoclasts, and this reduces their activity. So the osteoclasts reduces the activity of osteoclasts. This prevents the reabsorption of bone. However, there are a few key side effects to remember. These often pop up in OSCEs and exams, so just remember these 4 side effects. So reflux and esophageal erosions. So that's why, especially in OSCEs, when you're doing your prescribing, you need to put on the prescribing chart to take on an empty stomach, sit upright for 30 minutes before moving or eating, and also take with a full glass of water. These can also cause atypical fractures, osteonecrosis of the jaw, and osteonecrosis of the external auditory canal. So with any patients that you're prescribing bisphosphonates, it's really important to follow up these patients because obviously it's quite a potent medication that you're starting them on, so you need to make sure that they still need to be taken to be taking this medication. So all low risk patients, just follow them up in 5 years' time. So redo the FRAX score, redo the DEXA scan if it's indicated. All patients on bisphosphonates, you need to give them a FRAX and a DEXA scan after 3 to 5 years. And also keep in mind of putting these patients on treatment holidays. So you can put them on a treatment holiday if their bone mineral density has improved, so the score's improved, or if they haven't suffered any fragility fractures. A treatment holiday is a break from treatment, so you stop all treatment for 18 months to 3 years, and then you repeat the assessment again after 18 months to 3 years. So that's osteoporosis. We're now going to move on to osteoarthritis and rheumatoid arthritis. So I've written this little diagram. I'll put it at the end of the presentation as well, because it might make a little bit more sense at the end. But in rheumatology, things can, the 2 subcategories can be seronegative and seropositive. So seropositive refers to the presence of rheumatoid factor or anti-CCP antibodies, and seronegative means these antibodies aren't present. But I'll say this again at the end, so it might make a bit more sense. So osteoarthritis, it's important to remember that osteoarthritis is just wear and tear of synovial joints. This is not an inflammatory condition. So it's an imbalance between cartilage being worn down and the chondrocytes repairing it. So this leads to structural issues in the joints of patients. So risk factors are obesity, age, patient occupation, previous trauma, being female, and also family history is a big risk factor. So 4 key X-ray changes that you'd see in these patients. You'd see loss of joint space. So you can see here, this is the knee, the space between where the knee would be. You can see the loss of the joint space here. You'd also see osteophytes, which are little sticking out of bits of bone, really. You might also see subchondral sclerosis, which is like you'd see more dense white along the joint line, as you can see here. And you may see subchondral cysts, but it's very hard to see this on the X-ray, which are little fluid-filled holes in the bone. And just remember that by the mnemonic loss. So as you can see, this X-ray shows you've got, specifically in this is quite severe osteoarthritis. So you've got quite severe joint space narrowing here. You've got some osteophytes here, which are little out pouches of the bone. You've got subchondral sclerosis, so you can see it's like a denser, whiter line along the along the joint line there. So how do patients present with osteoarthritis? So they present with joint pain and stiffness. This stiffness, the morning stiffness of these joints will be less than 30 minutes. It will improve with rest. You normally get unilateral symptoms of just one side of the body. On examination, you'd feel crepitus in the joints. And the common joints affected are like large weight-bearing joints, so the hip, the knee, the carpometacarpal joint at the base of the thumb is also quite common, DIP and PIP joints as well. You'd also see some telltale signs in the hands. So you'd see Havardin's nodes and DIP, so here. You see Bouchard's nodes and PIP joints, so in these joints here. Squaring at the base of the thumb. These patients would also have weak grip and a loss of a range of movement as well. So how would you manage these patients? So the diagnosis is made upon the symptoms of having stiffness of the joints for less than 30 minutes in the morning, being over 45. No X-ray is actually needed to diagnose this. But the first step would be patient education. So you'd advise against weight loss, give them physiotherapy tasks, occupational therapy as well, so adapting their home to help them with day-to-day activities, orthotics, so insoles in shoes and things like that can help patients quite a lot. You'd then do stepwise sort of treatment, so you'd start with oral paracetamol and topical NSAIDs. You can then step it up to add oral NSAIDs, also prescribe a PPI with this to protect their stomach. You can then again step it up and prescribe opiates such as codeine and morphine, intra-articular steroid injection, and then you can then go on to replace the joints. The intra-articular steroid injections provide a temporary reduction in the inflammation, so they improve symptoms, but you have to get it repeated after 3 to 6 months. So rheumatoid arthritis, this is different to osteoarthritis because it's an autoimmune condition, and this causes synovial inflammation. So rheumatoid arthritis causes inflammation in the synovial lining of the joints, the tendon sheaths and the bursa. So antibodies that you'd see present in this condition would be the rheumatoid factor. So rheumatoid factor is an autoantibody, and it presents in about 70% of patients with rheumatoid arthritis. It targets the Fc portion of the IgG antibody. So all antibodies have an Fc portion on them that is used to bind the cells of the immune system. Rheumatoid factor targets this Fc portion on the IgG, and it causes activation of the immune system against the patient's own IgG, and it will cause systemic inflammation. You can also see anti-CCP antibodies. These are more sensitive and specific to rheumatoid arthritis than rheumatoid factor. Anti-CCP antibodies can also predate the development of rheumatoid arthritis, so it can give an indication that the patient will go on to develop rheumatoid arthritis at some point in the future. Rheumatoid arthritis has also got some genetic associations, so the HLA-DR4 and HLA-DR1 gene. So rheumatoid arthritis presents with joint pain. You'd see swelling and stiffness in the small joints of the hands and feet. You'd normally see symmetrical distal polyarthropathy. The onset, this can be overnight to months or even years. So there's a lot of variation in the onset of rheumatoid arthritis. The patient can also present with systemic symptoms, so weight loss, flu-like symptoms, fatigue. Rheumatoid arthritis is normally worse after rest, and it normally improves with activity, which is different to osteoarthritis. The morning stiffness would also last more than 30 minutes, and the PIP joints are most commonly affected, along with the MCP, wrist and ankle, and large joints. So you'd also see some telltale signs in the hands. So you'd see a Z-shaped deformity up to the thumb, so you can see the Z shape here. Swan neck deformity, Boutonniere's deformity, and you'd also see ulnar deviation of the fingers. So you can't really see it in this image very well, but you'd get ulnar deviation towards the side there. So what investigations would you do? So you do inflammatory markers such as CRP and ESR. You check the patient's rheumatoid factor first, and if it was negative, you then go on to check their anti-CCP antibodies. You check their urate, because a differential diagnosis could be gout or pseudogout. The synovial fluid of patients with rheumatoid arthritis will show polymorphic leukocytes. They'll also be yellow in colour, but you don't normally do a joint aspiration on patients with rheumatoid arthritis. So X-ray changes, you'd see juxta-articular osteoporosis, you'd see loss of joint space again. You see subluxation, which is a partial dislocation of the joint, and you'd also see periarticular erosions. So you can see that a little bit. You can see the bones eroding away a little bit there. I always remember this by JLS and then an extra P. I don't really know. I can never think of something for the P, but JLS helped me. Management of rheumatoid arthritis. So you start these patients on a DMARD monotherapy, so just one DMARD. So methotrexate is most common. You can also start these patients on a short course of prednisolone if it's particularly bad. You can then step these patients up if symptoms aren't being controlled to 2 DMARDs. And then the next step would be methotrexate plus a TNF inhibitor. And then you can finally step up to methotrexate plus rituximab. And for flare-ups of rheumatoid arthritis in patients, you can prescribe corticosteroids orally or IM. It's also important to note that pregnant women have an improvement in symptoms during their pregnancy. This is thought to be due to the higher natural production of steroid hormones. So lots of pregnant people say that the rheumatoid arthritis gets better when they are pregnant. So methotrexate interferes with the metabolism of folate, so it's important that folic acid is also co-prescribed when you prescribe the methotrexate. This should be taken on a different day to methotrexate, and the side effects, I've just listed them here, so mouth ulcers, liver toxicity, pulmonary fibrosis, bone marrow suppression, it's also teratogenic, so don't prescribe it to patients who are looking to have children. So gout. So gout is a type of crystal arthropathy, and it's associated with high uric acid levels. So risk factors for gout are male, obesity, having a high purine diet, so red meat and seafood, alcohol, taking diuretics, existing cardiovascular or kidney disease, and also having a family history of gout. So gout will present with normally just a single acute hot, swollen, painful joints. You can also see gouty tophi, which are like little nodules on the joints, and they're sort of white in colour. It's most often seen in the base of the big toe, and also in the base of the thumb and in the wrists as well. So as you can see here, this joint here and the base of the big toe here. So investigations you do, so you could do a joint aspiration, so you'd see no bacterial growth. This is important because you also need to rule out septic arthritis, which is obviously a medical emergency. With gout, you'd see needle-shaped, negatively birefringent crystals, and it's a monosodium urate crystals that you'd see. You'd also do some bloods, so you do the CRP, serum urate, U's and E's, LFT, and full blood count. On imaging, you'd typically, like the space between the joint is normally maintained, but you see these punched out erosions with sclerotic borders here, so like a denser whiter borders, and you'd also see overhanging edges like the ones shown here. You'd also see lytic lesions within the bone, so that's shown here. This is most common in the big toe, so this is gout on an X-ray. So you can see the lytic lesions. It's punched out sort of erosions here. So that's what you commonly see on X-ray. So management. An acute attack of gout is managed with NSAIDs, so ibuprofen first line. If patients can't take NSAIDs, then you can prescribe colchicine. So that's 500 mcg, and that can be twice a day to 4 times a day. So you prescribe colchicine in patients that have renal impairment or significant heart disease. It's also to be noted that colchicine causes GI upset in patients, so some patients can't tolerate it very well, so it's important to educate patients about this before prescribing it to them, for them. You can then also give intra-articular oral steroids, and that's more third line though, and also ice packs help these patients quite a lot. Obviously also educate them on lifestyle changes, so weight loss, staying hydrated, minimising red meat in their diets, reducing alcohol consumption as well as a big one. So that's for an acute attack of gout. If a patient presents with more than 2 attacks of gout in 1 year, have gouty tophi, which are these like whitish sort of nodules on the joints, or gout is present in a large joint, so the knee, for example, you'd want to start these patients on allopurinol, which is a xanthine oxidase inhibitor. So you'd start this and you'd monitor the serum lactate levels, and you'd want them to ideally be below 300. So it's important to note that you don't stop allopurinol in acute attacks of gout, but you shouldn't start allopurinol until the acute attack has settled. So someone presents with an acute attack, you treat the acute attack, and then if they have more than 2 attacks, gouty or present in large joint, you then start them on allopurinol. But if they then have another acute attack, when they're taking allopurinol, you carry on prescribing them allopurinol and then treat the acute attack on top of that. So Pseudogout, this is also a crystal arthropathy, but it's caused by calcium pyrophosphate crystals. Risk factors include hemochromatosis, hyperparathyroidism, acromegaly, low magnesium or phosphates, Wilson's disease, hyperthyroid is also present in older adults. It will also present with a hot, swollen, painful joint, but it's normally milder than gout. You typically, whereas in gout you see it in the big toe and in like the wrist, you typically find pseudogout in knees, shoulders, wrists and hips, but most commonly the knee. It can also affect multiple joints. So investigations, you do a joint aspiration, so you wouldn't see any bacterial growth, but you'd see these calcium pyrophosphate crystals. The crystals that you'd see would be positively bifringent rhomboid shaped crystals. You'd also do blood, so your CRP, serum urate, UNEs, full blood count and LFTs. On imaging, you'd see chondrocalcinosis, which is like a white sort of thin white line in the middle of the joint space, and that is caused by calcium deposition there. It would present on imaging similarly to osteoarthritis, so the lost mnemonic here. So you see on the X-ray, you can see like a slight, like a faint white line there, so that indicates pseudogout. So management of pseudogout is, so you normally see the chronic asymptomatic changes. If they don't have symptoms, then you don't need to treat them, basically. The symptoms, they normally resolve, and lots of people walk around with pseudogout and they don't know about it. However, if these patients are symptomatic, you'd firstly prescribe them NSAIDs. Again, if they're not tolerant, colchicine, joint aspiration also can help, and you can also give them low dose steroids orally if it's quite severe. You can also do a joint washout in severe cases as well. So septic arthritis, this is often quite a common exam question. It's a medical emergency, and it's most commonly caused by Staph aureus. Other bacteria known to cause it is gonorrhea, strep A, group A strep, H influenza and E. coli as well, but it's most commonly Staph aureus. So risk factors for developing septic arthritis include joint replacement, so recently having joint surgery, having rheumatoid arthritis or gout, being an IV drug user, being immunosuppressed, smoking, and also having diabetes. So septic arthritis normally only presents in a single joint, and it's also most commonly the knee. Patients will often present with quite a rapid onset of a hot, swollen and painful joint. The joint will be quite stiff, and there'll be a reduced range of movement of this joint. You'd also see patients present with systemic symptoms, so fever and like sepsis sort of symptoms. Differential diagnosis would be gout, pseudogout, reactive arthritis, which I'll go on to talk about in a little bit, and hemoarthritis, which is bleeding into the joints. Something like an exam tip to remember as well. So an exam question could be that a young patient could present with a single acutely swollen joints. Always think of gonococcus septic arthritis until proven otherwise. So a gonorrhea infection is quite common. And delaying treatment puts the joint in like quite high risk, quite a lot of danger. So in your exams, it might say the gram stain revealed a gram-negative diplococcus. The patient also might present with urinary or genital symptoms, and then that might trick you into thinking, oh, it's a reactive arthritis. But first, just remember that it's really important to exclude gonococcal septic arthritis first, because this is more of a serious condition. So septic arthritis, the Kocher criteria determine the risk of a septic joint. So this things included on this risk score would be the ability to not be able to weight bear on the affected side, having an ESR of above 40, having fever, and having white blood cells above 12,000. So if you've got any of these things present, then it increases your probability of actually having septic arthritis. So the management, it's really, really important to aspirate the joint before giving any antibiotics. So that would be your priority, and you send them straight away for gram staining, crystal microscopy, culture, and antibiotic sensitivities. So you do that first. That's really important that you do that first. Secondly, you get antibiotics into these patients as soon as possible. So it's normally flucloxacillin plus rifampicin. That's normally first line. Vancomycin plus rifampicin if they're allergic to penicillin, have got MRSA or a prosthetic joint, and clindamycin is also an alternative. So you give these antibiotics for 2 weeks IV, and then prescribe them orally for an additional 4 weeks on top of that. So it's 6 weeks of antibiotic therapy altogether. These patients will also be in quite a lot of pain, so prescribe some pain relief. It's really important. You need to drain the joint as well, and prescribe some IV fluids and DVT prophylaxis as well, because these patients probably won't be moving a lot because they'll be in lots of pain. So moving on to psoriatic arthritis. So this again is an inflammatory arthritis. It's normally present. It's present in patients with psoriasis. So you'd see patients with stiffening and soreness of the joints, and it's like a sliding sort of condition. So it can be mild joint pain over sort of the elbows and the knees, to completely destroyed joint, and that is arthritis mutilans. It normally presents asymmetrically, most commonly in the DIP joints, and the morning stiffness normally lasts over 30 minutes. It's also associated with conjunctivitis and anterior uveitis, aortitis as well, which is inflammation of the aorta, and amyloidosis. So signs of psoriatic arthritis. So there'll be obviously plaques of psoriasis on the skin. There might be pitting of the nails, oncholysis, dactylisis, and enthesitis. I think I've got some pictures. Yeah, so this, as you can see, this patient has got psoriasis, psoriatic plaques over the hands, and this is obviously quite a hot, painful, swollen joint of the wrist here. These are also some telltale signs here, so oncholysis and sort of nail pitting. So some investigations you do for psoriatic arthritis. So you'd want to take the ESR, CRP, U's, full blood count and liver function tests. You'd also check for rheumatoid factor and HLA-B27. You'd check for anti-CCP antibodies as well. And then a classic X-ray change to the digits would be like a pencil and cup appearance. So this is where there's central erosions of bone next to the joints, and this causes the appearance of one bone in the joint being hollow and looking like a cup, and the other is narrow and sits in that cup. So you would also see dactylitis, which is inflammation of the whole finger, and these are some other X-ray changes that you might see. So the management of psoriatic arthritis is the same as rheumatoid arthritis. So you'd start with your DMARD monotherapy, so your methotrexate. You can also prescribe a short course of prednisolone if it's quite an acute flare-up. You'd then move on to 2 DMARDs, methotrexate plus TNF inhibitors, or you can then step it up to methotrexate plus rituximab. So arthritis mutilans, which I mentioned before, that's the most severe form of psoriatic arthritis. So there's osteolysis, which is disruption of the bones around the joints in the digits. This will lead to progressive shortening of the fingers. The skin will then fold as the digits shorten, and it will present as like a telescopic finger because of this bone destruction, but then the skin is still present, so it would be almost like a telescope. So reactive arthritis. So this is a synovitis which occurs in the joints. It's normally after an infective episode, and Rita syndrome is normally the presentation of this. So it's important to distinguish reactive arthritis from septic arthritis. So septic arthritis is infection in the joint, and it's a medical emergency. But reactive arthritis, there's no infection in the joint. So causes, so it's normally after an infection, so a Shigella infection, Campylobacter infection, and or Salmonella infection, or chlamydia as well. The patients can develop reactive arthritis after a chlamydia infection. There's also a link with a HLA-B27 gene as well. So chlamydia is the most common sexually transmitted cause of reactive arthritis. But remember, so chlamydia is normally seen with reactive arthritis, but gonorrhea normally causes septic arthritis. Symptoms will be bilateral conjunctivitis, anterior uveitis, ballantitis, and asymmetrical arthritis. So that's your classic, the Rita's triangle, so can't see, can't pee, and also can't climb a tree. Management of this, So you'd just prescribe them antibiotics straight away until septic arthritis is excluded. So you need to aspirate the joints of these patients to check that septic arthritis, it isn't septic arthritis. So you'd want to send the sample for gram staining, culture, and also sensitivity testing. The aspirated fluid can also be sent for crystal examination to check for gout and pseudogout as well, because that's another differential diagnosis. So firstly, you prescribe an NSAID. You could also give steroid injections to the affected joints. Systemic steroids might be required, but it's normally if the patients have multiple affected joints. And mostly this will resolve within 6 months. It doesn't normally reoccur as well. But if it does reoccur, you might need to prescribe them methotrexate or anti-TNF medications. So just to look at this diagram again, so seropositive, so that's having the presence of rheumatoid factor or anti-CCP antibodies. So diseases that will show a presence of rheumatoid factor or anti-CCP. Example of these are SLE and rheumatoid arthritis. But seronegative, so rheumatoid factor isn't present, anti-CCP antibodies aren't present. So that's psoriatic arthritis, reactive arthritis, and also ankylosing spondylitis. I haven't had time to, we don't have time to talk about our ankylosing spondylitis today, but if anyone's got any questions, you're more than free to email me. So I've just got some questions here. I'm not quite sure whether people want to answer them in the chat or I can just show you the questions and you can just do it in your own time and I can work through them and I'll explain the answers. Yeah, well, I'll go through it and then you can put them in the chat, but if you're feeling shy, don't worry about putting them in the chat. So I've got 4 pictures here. I want you to label which picture shows gout, which picture shows rheumatoid arthritis, which picture shows hemochromatosis, and which one shows sarcoidosis. Okay, I'll go through the answers. If you're not quite ready, just mute me or just pop in the chat that you're not ready. But picture number 1, number 1, gout. So that is D. So you can see here the gouty tophi. It's like a yellow discoloring in these joints here. So that's an example of gouty tophi. Number 2, rheumatoid arthritis. So that is picture C. So you can see the patient's got ulnar deviation here, swollen joints, looks quite painful, but the telltale sign here is the ulnar deviation. Number 3, hemochromatosis. So that is B. And then sarcoidosis is A. Next question. So a 64-year-old man with a 15-year history of seropositive polyarticular rheumatoid arthritis is currently treated with prednisolone, 5 mg daily, and methotrexate. He's diabetic and treated with oral hypoglycemic drugs. For the past 3 weeks, his right knee has become progressively painful. On examination, there's a warm synovitis, an obvious knee effusion in the right knee with some stress pain. The left knee doesn't show, there's no symptoms or no signs shown in the left knee. Other affected joints are in his hands, wrists, elbows and forefeet, and they show some minor abnormalities but no sign of itis. So what would you do next at the clinic visit? I think this was taken from a Liverpool past paper question. So yeah, I found this question in, I think, can't remember what year it was, but I'll go on to the answers. So it is actually A. So it's because an infection of the knee is a most probable cause of the knee effusion. You'd probably need a hospital-based treatment, so you just admit them straight to the ward because you'd be worried about septic arthritis risk. And again, which of the following is most associated with osteoarthritis? So X-ray findings including subluxation, which is a partial dislocation or full dislocation of the joint, commonly affects the MCP or PIP joints, typically having bilateral symptoms, X-ray findings including periarticular erosions, and patients typically having pain following the use that improves with rest. And I'll go on to the answers again straight away because I know you probably all want to enjoy your Saturday. So it is E, so patients with osteoarthritis will typically have pain following the use that improves with rest. Which of the following is most associated with rheumatoid arthritis? I'll let you read it for a little bit. So X-ray findings including subconjugal cysts, patients having unilateral symptoms, commonly affecting large weight-bearing joints, X-ray findings including subluxation, and commonly affects metacarpal joints. So the answer to that one is D, so X-ray findings including subluxation. I think the second to last question. So a 56-year-old man comes to the GP complaining of his third flare-up of gout in the past 12 months. It's previously occurred in his right big toe, but it's now apparent in his right hand. He works as a builder, so these flare-ups are affecting his work. He has a past medical history, including hypertension, an MI 3 years ago, and asthma. Medications include amlodipine, ramipril, indapamide, aspirin, and atorvastatin. He's also clinically obese, and you've already given him lifestyle advice. So what is the next step for this patient? So would you start him on allopurinol, stop his aspirin, stop his amlodipine, stop indapamide, or start with roxaban? So in this patient, the correct answer is D. So you'd stop indapamide, which is a thiazide diuretic. So these drugs are typically known to precipitate acute attacks of gout, and so you should avoid prescribing them in patients with a history of gout. So it'd be most appropriate to stop indapamide and start a different antihypertensive agent. Hypertension is also a risk factor for gout flare-ups, so it's important that you maintain good control of his blood pressure. Last question. So a 42-year-old woman comes in with a 2-month history of fatigue, tingling in her fingers in both hands, pain radiating into the hands and forearms. She has difficulty opening bottles. The tingling symptoms are stop sometimes when she shakes her hands in the morning, but she typically has 2 to 3 hours of morning stiffness in her wrists and fingers. She takes no medications. She's got a normal BMI, soft tissue swelling and tenderness in the wrists and metacarpophalangeal joints bilaterally. So what should be the cause of this patient's neuropathy? So osteoarthritis, an overuse injury, polymyalgia rheumatica, rheumatoid arthritis, or carpal tunnel syndrome. So the answer to this question would be D, rheumatoid arthritis. So some telltale signs here is the 2 to 3 hours of morning stiffness. It's the wrist and the metacarpophalangeal joints bilaterally, soft tissue swelling and tenderness, and also the 2-month history of fatigue as well. So she's got some systemic symptoms present there. So I've got another question, but it's quite a long one, so I'll let you have my slides and you can work through those yourself, and the answers are on like the notes underneath. Here's a little table that I found quite helpful too, because I found osteoarthritis and rheumatoid arthritis quite hard to differentiate between them. So it's quite good to be able to differentiate those two. And that's it. If you could fill out the survey, I think